prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and fear. I thank everyone. I welcome our President, Sir, Dr. S.B. Lakkod, Sir. Sir is busy today, so he may come in between. And our Secretary, Sir, Dr. Karunakar, Sir, who always guide us in organizing the web talks and also in other works related to IMA KSP. I welcome our Bidar Branch President, Dr. Vaishnath Madhanna, and the Secretary, Dr. Mallikarjun Panchetti, for taking special interest in organizing this talk on the eve of International Women's Day. This year, Bidar IMA is hosting a Medicon, the state IMA conference. So we request everyone to register for that Medicon. So I welcome our speakers, Dr. Savita, Dr. Jyotsna, Dr. Rameshwari, who are faculties of medical colleges and consultants in their respective hospitals. I welcome our chairpersons for accepting the invitation and giving their precious time. Dr. Anuradha ma'am, who is a backbone of IMA, Dr. Meenakshi Devarmani ma'am, who is my mentor and also faculty in MR Medical College, Dr. Manpreet Kaur ma'am, who was a faculty in BLD and Alameda College, and she's a state IMA WTW chairperson. I welcome all the delegates who have joined through Weblink and also through YouTube. So now I request our Secretary, Dr. Karunakar sir, to say a few words.
Thank you, madam. Thank you so much. Good evening, everybody. It's been an honor to really speak few words on behalf of IMA KSP President Dr. Lakkod sir, who is touring Dakshina Kannada branches and he's been really busy since yesterday actually. I remember this time he's visiting close to about 12 branches in a period of 2 days. It's very extraordinary. So if you find time, we'll join in between. Signal could be another reason. But I take this opportunity to represent him and our IMA KSP. I take this opportunity to appreciate Dr. Sanjana and team, the academic committee, for doing a wonderful academic activities month after month. It's been regular and it's been well appreciated. I'm sure in the time to come, we're going to have much more, even more intense academic activities to go on, helping our students, both undergraduate, postgraduates, beside helping our members to learn about new things about it. And today's meeting is quite unique with that. Madam has selected people from Bidar, the host of upcoming Medicon conference. It's been an opportunity for all of us to really support Bidar team and also to register as early as possible. Another important thing in today's meeting is that she has ensured that faculties from Bidar are speakers today. Instead of one session, there are 3 sessions today. And that's the way to go forward. Maybe this experiment should inspire academic team to really look at how innovative things can be brought on the board for bringing much better academic activities, like maybe some kind of debate, sometimes it could be symposium, sometimes it could be even just interaction with a legend of a profession. Actually, there are many things which could be looked at over a period of time. It could also be possible, like today's meeting, we could also plan for specific aspect programs also. So everything is possible, and of course, IMA KSP is very happy with the academic works done by the academic committee. With these few words, I would like to sincerely thanks for giving me this opportunity. It's back to the chairman. Thank you so much.
Thank you, sir. Thank you for your speech, sir, and also guidance. Now I request our postgraduate student, Dr. Prachi Korwar, who is also from Bidar, and she is a daughter of well-known gynecologist, Dr. Prakash Korwar, sir, to take over the platform and introduce the speakers and chairpersons.
Thank you so much, ma'am. Good evening, everyone. I request Dr. Savita Badgar, ma'am, consultant gynecologist, Navjeevan Hospital, Bidar, and she's even a faculty of Bidar Institute of Medical Science, to enlighten us on our first session, that is puberty and adolescence problems. And to chair the session, I request Dr. Anuradha Parmesh ma'am, consultant gynecologist. She is immediate past president, IMA Bangalore, member of IMA KSP WDW. I request Savita ma'am, please enlighten us on today's session, ma'am.
Good evening, ma'am. Good evening, all. Myself, Dr. Savita, consultant, Navjeevan Hospital, Bidar. Today I'll be dealing.
John, screen full ಮಾಡ್ಬಿಟ್ಟು. Hello? Okay. Now you-
ಮಾಡ್ತಾ ಇದೆ. It's full?
Yeah.
Okay. Savita, you
Yes,
continue.
ma'am. Yes, ma'am. Good evening, ma'am. I'm Dr. Savita, Navjeevan Hospital. My topic today is puberty and adolescence problem. Adolescence is a phase when children go through several changes as the journey from childhood to maturity. It is also a vulnerable time for children since may experience several problems of adolescence. Concerns about adolescents' behavior are also common during this time, making it difficult for parents to connect with their children. Next slide. Let us know about the current statistics. The population of adolescents in India is 243 million. Population of adolescents in Karnataka, 12.9 million. And more than 50% of adolescents are anemic. 45% of the girls are married by the age of 18 years. And 10 to 15% of the total births is teenage pregnancy. 4.4 million adolescents undergo abortions every year. 330 million new STI cases are reported every year. Next slide. We know that from the toddler to our old age, we undergo many phases in our life, and among them, the adolescence plays an important role. The adolescence marks a time, a great change in the physical development. Next slide. Who is an adolescence? Adolescence is a period between the 10 to 19 years of age. WHO clearly recognizes that it is a phase rather than a fixed time period in an individual's life. It is a development on many fronts, like the appearance of the secondary sexual characters, the sexual and the reproductive maturity, the mental processes and the adult identity, the emotional dependency to relative independence. Next slide. This is a normal process seen in both the sexes. It is seen much earlier in girls than in boys. It varies from one person to another, and it is responsible. The hormones responsible for these changes are, in girls, it is estrogen, progesterone, and in boys, it is testosterone. Next slide. Adolescence marks a time of great changes in the physical development. It's a time when teens question what's happening to their bodies and what's normal. They often compare themselves to their friends, noticing the differences in the heights as they stand in the line or their bodies as they change into the gym clothes. Sometimes these changes in the development can trigger both parents and teens to have concern. Those issues can range from concern about puberty, physical development, self-esteem, and body images. Now let us learn about the common problems faced in the adolescence. The most common problem, first one, is the physical change. Development of full breast in girls, the change of voice and appearance of facial hair in boys, development of acne, the muscle gain, excessive body weight, and the pubic hairs in both the sexes, and girls starts having their periods. Next slide. Now, the menstrual issues. Girls may be concerned about when they'll get their first period and what to do if their periods is irregular. It's a normal for a menstrual cycle to be irregular up to 1 to 2 years after first getting one's period. But ongoing irregularity could be a cause for concern. Consider an evaluation if your adolescent has not received her period by 16 years of age, or if the menstruation causes severe pain or extreme mood changes. If there is a mild pain or a backache or an abdominal discomfort, which is very common during menstrual cycle, and if it is severe, see a doctor. Next slide. Hormonal imbalance can cause heavy menstrual bleeding. It might be frequent, excessive. This has to be addressed in the adolescence. Next slide. Next slide. Premenstrual syndrome. This one is of concern in many adolescents and in the pubertal age period. Many of the girls comes with mood swings, stress, diarrhea, bloating sensation, headache, acne, cramps, abdominal pain, and lower back pain. And all that they need is reassurance. And if it is in a severe form, need to be provided with the medications. Next slide. Polycystic ovarian syndrome. Now, this is the rising topic seen in most of the adolescents and the pubertal girls. About 30 to 36% of the girls are suffering with this PCOS. And as we know, it is because of the hyperandrogenism leading on to acne, hirsutism. Then how to overcome all those things is, if it is not that, can be treated with an oral contraceptive pills. And the symptoms includes most of the time. Next slide, please. Irregular or absence menses, acne, hirsutism, alopecia, dark velvety skin under the arm and neck, acanthosis nigricans. Next slide. Now the question is there a rise of PCOS? Next slide. Yes. The answer is yes to this question. There is a rise of PCOS now in this adolescence and pubertal in this era. And the most common cause, we do find that it is usually associated with obesity. Next slide. Now, obesity is associated with irregular menstrual cycles. There is a high risk of developing early onset hypertension, high risk of developing early onset diabetes, and there might be an increased blood cholesterol levels. Next slide. Why is this obesity associated with so many other complications? And the cause for this is the sedentary lifestyle. Next slide. We also find that the non-exercise activity thermogenesis, which is in the farmers, we do find that it is 2000 kilocalories per day. And in the adolescent girls or pubertal girls, it is about 700 kilocalories per day. Next slide. Also, taking junk foods is also causing one of the cause for obesity. We have found that excessive consumption of calorie-dense food has been associated with this obesity. And the soft drink sale was noted with a statistic of 76% increase in the past 5 years. And for example, the 300 ml of cola contains 132 kilocalories and 40 grams of sugar, leading on to most of the junk foods and leading on to obesity. Next slide. With this physical problems, the another problem which is associated with the physical changes in this adolescent period is white discharge. Some vaginal discharge is normal in adolescence. However, when there is an unusual discharge, this might be a result of any infections. It can be because of cervical infections or any fungal infections which need to be addressed by the healthcare provider. Next slide, please. Now, what is the solution to this? Parents can reassure their teens that many of their concerns related to their bodies are normal. We must validate their feelings and normalize what they are going through. At the same time, we must not be afraid to seek professional help. Any concerns related to delayed puberty, slow development, body image issues, acne, painful or irregular periods, and more are common topics with which healthcare providers are trained to assess and resolve. So awareness about these changes, explaining that it is normal and enable them to stay healthy is a solution to these physical changes in adolescence and puberty. Next slide. Now, the next problem which we usually face is the sexual health problems. The development of secondary sexual characteristics during adolescence gives rise to new feelings in teenagers and pushes them to experiment with their bodies. Without proper guidance, teenagers may become sexually active before they are ready. This could result in unwanted pregnancies. Unwanted pregnancies is the biggest risk that the adolescent girls face. Next slide. The consequences of this unsafe sexual behavior can lead to unwanted pregnancies, unsafe abortions, HIV/AIDS, sexually transmitted infections, chronic pelvic pain and infertility, and cervical cancer. Next slide. What is the solution to this problem? Talk with the child about the sexual health. Talk with your child as they may already be learning about the sexual health and reproduction at the school. Your duty as a parent is to ensure that they understand the importance of safe sex. The hormonal changes in the teenagers may make them act impulsively. Your adolescents may not like it, but it is important that you talk to them about the consequences of the unprotected sex and how it can change their life. Awareness is the only way to prevent early pregnancies and the sexually transmitted infections in adolescents. Next slide, please. The third problem which we have seen in the adolescence and the puberty is the health problems. Adolescents are vulnerable emotionally and physically. Without proper nutrition and health care, they are susceptible to illness. According to 2015 stats, WHO reports that 1.3 million adolescents died in the 2015, and that too with their preventable diseases. Teenagers have a hectic schedule as they hop from one activity to another with a little time to eat or rest properly. So unhealthy eating habits prevent them from getting the nutrition that they need. Stress can also lead to loss of appetite and sleepiness in children. Next slide. So a concern about the adolescent nutrition is a very important note. There is an increased need to know about the adolescents. This is because the adolescent gains up to 50% of their adult weight, 50% of their adult height, 50% of their adult bone mass, muscle mass. Adolescent girls need additional iron to compensate for the menstrual blood loss. Next slide. So we find that anemia is noted more in adolescents. And why is this? That is because of the increased demand. There might be a deficiency in the diet. That is because of the food taboos or the fussy nature of the adolescents or the negligence of the adolescents, a loss during menstruation, worm infestation, and bad cooking habits like overboiling and all. Next slide. How to overcome this? The simple measures. We have investigations to know whether the adolescent or the pubertal is having anemic or not by simple hemoglobin percentage estimation and correction by giving iron, folic acid, and also deworming it. Next slide. Encouraging them to have iron-rich sources. And we know that citrus foods have also causes increased in the absorption of the iron. Next slide. Next slide. Yes, we have found that exercise and physical activity also makes our adolescents to be healthy. So it improves your strength and endurance. Bones and muscle mass becomes more healthy. It avoids weight gain. It reduces the anxiety and stress and increases the self-esteem and confidence. Next slide. The third important emotional problem which the adolescent face is the emotional health problems. Adolescence is the age between adulthood and childhood. Teenagers are often confused about their role and are torn between their responsibility as growing adults and their desires as children. They tend to feel overly emotional just about anything and everything that can make them happy, excited, mad, or angry. Next slide. Next slide. So the emotional changes in adolescence is the anxiety about the body change, the mood swings, the overreacting over small matters causes increasing irritability, restlessness, and anger. And it is this point where they develop the self-esteem, self-image, and self-confidence. The questioning and rebelling activity against the existing norms also increases during this phase. Next slide. As a parent, we find that what's going wrong with an adolescent, why they're not talking to us, not listening to us. As an adolescent, I feel, why my parents are not understanding me? What's the point? Where are the normal parents gone? And the only solution to this is the communication. Next slide. Next slide. Next slide. So how to communicate, how to overcome this point? So to manage this, or to manage the stress level, often we overburden ourselves with stress. Always count your blessings in life, what you have in your life, accept the circumstances which cannot be changed, and effectively conquer stress before it engulfs you. And then next is plan, plan, plan. Be organized and complete the task in hand. Next slide. In case if the stress is not managed, then our adolescence ends up in sadness, and this extreme form of sadness going on to depressions. And the extreme form of depression is the suicidal tendencies. Next slide. We do find that the suicidal tendencies are on the increasing trend in this adolescence, in this era. So how to overcome this? Communicate with your parents, discuss with the trusted adults about your personal problems and feelings. Don't decide anything which is taken in anger or depression. Even a joke about suicide or an intention to write a suicide note is to be taken very seriously by the adult. Next slide. To overcome this suicidal tendencies, depression or sadness, spirituality also can do help us, as we know that spiritual individuals strive towards a better life and consider personal growth and the fulfillment as a central goal. Spirituality is not the same as being religious. Even a 10 minutes of meditation a day can help you strengthen your subconscious and achieve your goals. Next slide. So all this were the few problems which the adolescence and the pubertal period, this thing they used to face. Now we have there's a very important thing about during the adolescence period, that is the vaccinations. Next slide. We do have vaccination, that is the vaccines which help to prevent diseases or minimize the having an infection or a disease. Next slide. 2 important vaccines for these young girls have been given, that is rubella infection and for cervical cancer infection. Next slide. Rubella vaccination must be given at least 3 months before pregnancies. 1 dose protects for 18 to 20 years and cannot be taken during pregnancy. It is safe and easily available. Next slide. Cervical cancer, it is the cancer of the lowermost part of the uterus and the second most cancer, leading on to 60,000 of deaths in India. And the most common causative organism for this is human papillomavirus. It is noted that 99.7% of the cases of cancer is because of HPV infection. Next slide. Prevention of this cervical cancer can be by routine pap smear, HPV vaccination, and also HPV vaccine available, which is an excellent measure for the prevention of cancer cervix and available in the 3 shots, 0, 2, and 6 months. Next slide. You don't need to be any older than today to change the world. I end my topic with this slide. As we see these achievers who have done achievement at a very younger age during their adolescence period. Thank you so much.
Thank you, Dr. Savita, for that elaborate presentation covering all aspects of adolescence and puberty. Any questions we can take later? Is it Sanjana?
Later, madam, after all the 3 sessions.
So I request the Dr. Prachi to take over.
Thank you so much, ma'am, for such a wonderful and informative session. Now moving on to the second session. Now I request Dr. Jyotsna Hanamshetty, ma'am, consultant gynecologist, Sangameshwar Hospital, Bidar, and faculty of Medical College, to brief us on common gynecological problems. And I request to chair this session Dr. Meenakshi Devarmani, ma'am, my mentor throughout. I've been fortunate enough to be mentored by her, and she's professor, Department of MR Medical College, Kalburgi, and she was organizing secretary for 25th Kasoga 2014. Over to you, ma'am.
Yeah, thank you, Dr. Prachi. Okay. Good evening, everybody. Today's my topic, as you said, common gynecological problems. Basically, I'll be talking about gynecological problems in obstetrics and again in gynec patients also. Okay. So myself, Dr. Jyotsna Praveen Hanamshetty, consultant and gynecologist in Sangameshwar Hospital, Bidar. So when we talk about non-pregnant patients having gynec problems, they are n number of gynecological problems. They are like menstrual problems, cervical and vaginal discharge. They will have pruritus vulvae, swellings of the vulva, cervical dysplasia, prolapse, pelvic pain. Dr. Savita just now told about PCOD, which is more common in adolescent, also in adult age, uterine fibroids and urinary incontinence. So one by one, I'll be dealing with each topic. Okay. So then when common problem, very common, every alternate patient in our OPD is menstrual disorders. So every alternate patient will come with either menorrhagia, metrorrhagia, it can be dysmenorrhea, intermenstrual bleeding. So we have to deal with all these problems. So many patients, they will tell that heavy and prolonged bleeding for long periods, or post-coital bleeding, painful cramps. So there are n number of causes for that. As we all know, abnormal uterine bleeding, it has structural and hormonal causes also. So for commonly, we see endometrial hyperplasia, cancer, endometrial polyps, endometriosis, PCOD. So when we start investigating, n number of problems are there. So first, very important thing in such patients is history. Very important. Because from childhood, some patients will be having some coagulopathies or thrombotic disorders that we will come to know only by asking history. Or sometimes she'll be on some medications. So again, the next part is clinical examination. As Savita madam told, in PCOD, everything will be seen on the patient. If we do thorough clinical examination, acanthasis and nigricans, all hyperandrogenic signs we can see on the woman. So that we can diagnose. When we talk about endometrial hyperplasia, as per by history only will come to know anovulatory cycles. Okay. So oligoamenorrhea or amenorrhea, or they will have menorrhagia after 3 months of amenorrhea. So like this. So polyps will be again post-coital bleeding. So by history only will come to know. So the thorough history and clinical examination is very important. I have seen many times peripheral doctors, they are sending the patient with menorrhagia treated with n number of hormones, but on simple per speculum examination will find a polyp. So we can just treat. So history, clinical examination, then we'll go to the investigations. When we talk about investigations, then we can take a help of biopsy, scans. We can do a good ultrasound with a radiologist. Okay, so then when it's a polyp, sonogram is also useful. Okay, like that. Then we can treat accordingly. What is the cause? For simple dysmenorias, NSAIDs. For endometrial hyperplasias, we can use with hormone pills, patches like that. IUDs like levonorgestrel IUD, Mirena nowadays, it is commonly used for most of the menorrhagia and menstrual problems. When we talk about surgical options, we have hysteroscopic endometrial ablation, then uterine artery embolization, mainly for the leiomyomas and fibroid. When it is a perimenopausal woman with fibroid or endometriosis, adenomyosis, then we can go directly for the hysterectomy. So I'll not go in detail of each and every problem. So how patients will come to our OPD. The second very common is nowadays, as because of Google and more awareness, people are coming with pap smear report. So most of the, like when we get a pap smear report, amongst 100 reports, and 10% reports will be like dysplasia report. In that, most of the patients will have mild dysplasia. So what is dysplasia? We all know about that. It's a precancerous condition of the cervix. It's basically caused by human papilloma virus. So that's why the woman, it's like, it's must nowadays to have an annual examination with a gynecological person. And after 21 years, when they become sexually active, every yearly pap smear should be done as per the FIGO guidelines. Okay. So why I'm telling this, like, when we talk about this pap smear report, as we like, WHO classification is there. We have SIN 1, 2, 3, and CIS. So when it's a SIN cervical intraepithelial neoplasia 1, we are okay. Because when we see this, actually, I don't have a pointer right now, but when we see the progression to the invasion, it is less than 1%. So we are very much calm in this condition. But when it goes to 2 and 3, so we have to be very much alert. And when it jumps from 2 to 3, that we don't know. So that's why every year annual examination along with human papilloma virus screening, that everything is very important in such patients. So always pap smear for any gynec patient who comes with white discharge or just pruritus vulvae, we have to get a pap smear. And after 21 years, as per the FIGO, every year annually we have to get the pap smear from 25 to 65 years. After 65 years, for last 10 years, if it is negative, not needed. Okay. So as I told you, mild dysplasia, we have to just see for annually. For moderate and severe leap biopsy, we can take, or colposcopic directed biopsy, we can take. Then as Dr. Savita told us, we can go for the HPV vaccination from 9 to 11 to 26 years, just to protect from the HPV related cervical intraepithelial neoplasia. The third very common problem in gynec patients is pelvic organ prolapse. What exactly is a prolapse? It's the prolapse of the vagina when the woman becomes weak, like after a repeated childbirth, because of chronic constipation or because of weakening of the tissue. When there is prolapse, when the connective tissues who held the vagina, bladder, and rectus, they become weak, that time along with the vagina sags down. Along with that, all the pelvic organs like bladder, rectum, they will sag down and uterus, they will have prolapse of the uterus. That is called as pelvic organ prolapse. So most of the time, the symptoms are very often, especially rural patients, they just neglect it till it becomes outside the vagina or it's a 3rd-degree prolapse. So initially they will just have mild discomfort or little bulge in the lower abdomen. But when it becomes severe and there is more weakening of the pelvic floor muscles, that time they will have visible bulge outside the vagina, pressure sensation in the vagina. They will have difficulty in the starting and completing the urination and bowel movements, vaginal irritation. Okay, they will feel very loose down in the vagina, or they cannot keep the tampon. They will have even, they cannot even enjoy the intercourse. So as we all know, for the 1st-degree prolapse, only the Kegel exercises is enough. And we can just tell about vaginal pessary option to them. Okay. And they can just have a good diet. They can just strengthen their pelvic floor muscles with the Kegel exercise. But 11% women, they require surgery. Either way, we all know vaginal hysterectomies with all anterior-colpography, posterior-colpoperinegraphy, we all are well versed with the surgeries or minimal invasive surgeries like lap sling operations for the prolapse, especially in the young patients. The very next common problem in our OPD patients is chronic pelvic pain. Every single patient in gynec OPD is having chronic pelvic pain. So what they will tell, they will just tell from the umbilicus to the pubic bone, they have some pain and it is there since long time. They will be very much depressed with the pain. The family members will not tell anything. They will tell, we have done the scan, nothing is there on scan. It is there is no problem. Actually, there is some problem because in 6 months she is having some problems. We have to evaluate. Sometimes on scan, like endometriosis, PID, we cannot see on scan. So laparoscopy is a gold standard for such conditions. Then we have to go for the laparoscopy, see, put a scope, see what is there. If we can help that woman, if chocolate cyst is there, we can remove, or any adhesions, we can just release that, which will have the relief of pain for the woman. So usually it's a very discomfort, periodic menstrual cramps will be there. And this chronic pelvic pain, which they cannot manage with any painkiller. Whatever painkiller you give them, they said, no, there is no relief of pain. Okay. It can range from dull to a sudden, very sharp pain. They have the common symptoms like cramping, pressure in the pelvis, pain during sexual intercourse, pain during urination or bowel movements, change in mood such as depression. So whenever they come in the OPD, they will come with so much of wrinkles on their face because she will be neglected in the family. Everybody will tell nothing is there and simply she is telling pain. But we have to give her sympathy. We have to counsel her properly and we have to find out what is the cause for her pain. If there is no cause, we can just counsel her positively that nothing is there in a positive way, then they will automatically it will come down. The psychological part is very important in such patients. So as I told you, by prior records, thorough pelvic examination, ultrasound, MRI, histoscopy, and also I want to add in this laparoscopy is also gold standard for especially PID and the endometriosis conditions. So same thing for the pain, NSAIDs we can try, infection control if it is a PID. If any cause, we find out treatment of the cause, minimal invasive surgeries, and very rarely, we can go for minimally invasive USG-guided nerve block or trigger point injection therapy. So next very common condition, what we meet across is uterine fibroids. So nowadays for a hysterectomy, the commonest cause is uterine fibroids. So the most commonest cause, almost like, it's 20% incidence is there, this fibroid. So we all know what are the types of the fibroids, submucous, intramural, subserous. We are more worried about the center part, intramural, because it is very much symptomatic for the woman. Painful cramps and also submucous. They will have menorrhagia. Subserous, unless it's a very large in size, it will not cause anything. And this is subclassification of the fibroid, which is very important only for the laparoscopic surgeons or for the infertile patients. So when it's a submucous fibroid, just especially when we go for the resection of the fibroid, we should know what type, whether from 0 to 7, it is what type of subclassification, so that we can plan our surgery. So as we know, submucous, we have 3, less than pedunculated, less than 50%, more than 50% intramural part. And also in the from intramural to subserous, they are 3 to 8. So as we can see in the figure, half part in the intramural, then half part in the submucous, like that. So only for the resection purpose for the laparoscopic surgeon, this is more important. As in clinically, this 0 type and this intramural part will cause more menorrhagia and pain. Then when we talk about symptoms, large fibroids, as I told you, they will have menorrhagia, abdominal pressure, bulging, urinary issues. Especially I have seen many patients in the OPD coming with retention of urine. When it's a very large fibroid, fundal fibroid, which will press on the urethra, and they will have a retention of the urine. And commonly constipation, lower back pain during sexual intercourse, anemia because of menorrhagia, because they'll bleed a lot, so their HB will go down. Infertility, as I told you, submucous fibroids, endometrial polyps, so they will have difficult implantation and infertility. So there are many treatment options. We all are very well known about that. So like hormone pills, we have nowadays this progesterone, selective progesterone receptor modulators like urliprestol. Okay, we have danazol, GnRH agonist. Just to these are all like medical menopause. They will just reduce the size of the fibroid when we are planning for any surgery. But actually, correctively, if it's a large fibroid, we have to go for the myomectomy. If it's more than 6 to 7, I don't think so. They will come down with all these hormone pills or these modulators. So we have to go for myomectomy, or nowadays uterine artery embolization with polyvinyl alcohol also is done in higher corporate hospitals. If the woman has completed family, or there is no if she's perimenopausal, we can directly go for the hysterectomy. So the next very common symptom in gynec patients is urinary incontinence. Urinary incontinence is which is inability to control release of urine. So it can be caused by temporary problems. Commonly it is because of UTI, especially in this season, summer season, they will have dehydration, they will drink less water. So commonly they'll come with incontinence of urine or UTI. Changes in the muscle and nerves around the bladder, that is also one of the cause for UTI. Incontinence. It can be stress urinary incontinence or urge incontinence. Stress is like because of coughing, sneezing, they will have leakage of urine. Urge is they will have sudden strong need to urinate and they will have incontinence. So this is basically when it's a simple UTI, we can treat from our gynec side. But if it is because of some other neurological problem, we have to send to the urologist. They will take care of all those things. So exercise medicines from our side, we can just tell the patient. Then we have n number of infections in the vulva, Bartholinitis, and very common thing what we see in our OPDs is Bartholin's abscess or Bartholin cyst. For that, we all know we can just do marsupialization of the cyst and we can get rid of that problem for the woman. Also vulvogenitis, especially in the childhood, we have to look for the foreign bodies. And common infections in the vagina, trichomonas, candida. In perimenopausal women, atrophic vaginitis, cervicitis. So very common upper GI tract infection, that is PID, next very important problem, which involves endometrium, fallopian tubes, ovaries, pelvic peritoneum, surrounding structures. It is the incidence is 1 to 2% per year among sexually active women. So there are symptoms like I told you, lower abdominal pain, pelvic pain. So this pain is there for each and everyone. We have to just find out the cause very keenly. Why she is having pain? We have to listen to the patient very keenly. History and clinical examination, exactly where she is locating the pain and what is troubling to her a lot. When we listen very clearly, sometimes we will find out the cause. Then fever, lassitude, headache, excessive and irregular bleeding because of endometritis, abnormal vaginal discharge, nausea, vomiting, dyspareunia, pain and discomfort in right hypochondrium because of adhesions there. So we all know about this minimum criteria, additional criteria for the diagnosis of PID. Okay, when there is temperature, raised C-reactive protein, how to treat that, outpatient department OPD, what we have to give. We formally give doxycycline. If it's a chlamydia infection or any aerobic infection, we have to add the metronidazole. We all know about this. Okay. When it's an inpatient, when we have to admit, that we should know. Suspected pelvic abscess, severe illness, temperature more than 38 degrees Celsius. Okay. Emergencies like ectopic pregnancy, when the patient is unresponsive to outpatient treatment like our tablets. Okay, intolerance to oral antibiotics. We cannot just wait like that. We have to admit the patient and give IV antibiotics. This is the regime for the IV antibiotics like cefoxitin 2 gram IV 4 times a day for 2 to 4 days. And we have to add metronidazole also. The very next common infection is genital tuberculosis. Especially it is more common in infertile patients. The incidence is 1%. It is high 5 to 10% among infertile patients. Symptoms are anorexia, infertility, menstrual problems, chronic pelvic pain. We have to find where is the primary, either it is the lung or where exactly. Then we have to confirm the genital lesion and treat with the help of the physician with AKT, general treatment of the patient to improve his health, her health, and surgery. The next very common is infertility. Infertility, we have to again find out whether it is primary, secondary infertility, and we have to refer the patient to the infertility specialist. Then injuries of the genital tract, this I want to elaborate. One common patient that comes to our OPDs, especially in the rural areas, fall in the farm. Okay, they will have injury when they take it out sugarcane in the farm. So very bad genital injuries they'll come with. That is vaginal tears, and commonly postcoital vaginal tears also they come to the OPD. That also we can treat. Everybody knows that. Malignancies of the genital tract, CA cervix, very common. CA ovary, CA endometrium. CA endometrium especially in the perimenopausal and postmenopausal women. Now next we'll go to the basic reproductive problems in the obstetric patients or pregnant patients. They are Mullerian anomalies like anomalies of the uterus, leukorrhea, retrovirgin, prolapse in the pregnancy, torsion of the uterus, uterine fibromyomas, ovarian neoplasms, and CA cervix. So Mullerian anomalies, they are acute uterus or small septate uterus, they will not cause anything with the obstetric career. They will not interfere with the obstetric career. But when it comes to the septate uterus, it will definitely cause abortion in most of the women. Septate uterus can cause even PPH also. Bichordate uterus, if it is there, then it can cause mainly, it will not cause anything, but there will be malpresentations. We have to just follow the pregnancy till end, breech or oblique lie like that. Pregnancy in the rudimentary horn can cause rupture in the second trimester. So we should know in the first trimester when we are doing the early pregnancy scan, we have to not only have to see the viability of the fetus, we have to see the anomalies in the uterus, tubes, ovaries, everything will come to in the first trimester scan only. Then when we talk about leukorrhea, due to pregnancy hormones, there is hyperemia and increased vaginal discharge. As long as this discharge is not excessive and it is not accompanied with irritating symptoms, we have to just counsel the patient. But when it is associated with dysuria, pruritus, vaginal discomfort, and any other irritation there, then we have to treat the patient. But if it is not having with any irritation, then we can just counsel the patient. We can tell her to have high protein diet, fruits, vegetables, and then we can just tell about her hygiene and we can follow the patient. Vaginal infection can predispose them to PRM and preterm labor. That's why we have to counsel the patient. The very commonest infection in the pregnancy is candidal infection or monilial vulvovaginitis. It's because of due to Candida albicans. It's very common in pregnancy. The patient complains predominantly pruritus vulva and secondarily of thick curdy white vaginal discharge and also dysuria. And there is excoriations on the vulva. So what we have to do, we can just give local antifungal ointments, and oral also we can give after first trimester. Actually, it's a class 3 drug, but we will not give in the first trimester, we'll give in the second trimester. And the next common is trichomonas vaginitis. It's a second common cause of vaginal infection in pregnancy. The patient presents with foul smell of further discharge with vaginal irritation or itching. Occasionally, it causes a blood-stained discharge in later pregnancy. The treatment of choice is metronidazole. The very next common is bacterial vaginosis. In this condition, the normal vaginal flora is replaced by anaerobes like Gardnerella vaginalis, Mycoplasma hominis, anaerobes. Okay, women with BV may complain with a whitish or greenish vaginal discharge with unpleasant odor as like fish-like smell. So we have to diagnose it. We have the AMSIS criteria. We all know about that. There are 6 criteria for that. Then next is retroversion. Normally we don't see this. Just I have told it in 15 to 20% it is there. Spontaneous correction, it occurs in the retroverted uterus because as the uterus grows, it will become the retroversion gets corrected. But sometimes it will not get corrected and the uterus remains in the pouch of Douglas, then it's very difficult. But as long as there is no problem, we should not disturb the pregnancy. But if there is incarceration or anything, we have to do the surgery. Then the prolapse in the pregnancy. Uterine prolapse, complicating pregnancy has become less common because when the pregnancy advances, when the pregnancy occurs in the pre-existing prolapse, when the pregnancy increases, the prolapse itself gets corrected spontaneously in the second trimester. The fundus grows out of the pelvis and rest of the above the pelvic ring. This draws up the cervix with it and minor degrees of prolapse gets corrected. But sometimes they will have mass per vagina, leukorrhea, cervical dystocia, especially during labor. That time we have to be very cautious. Urinary retention during pregnancy. Then in pregnancy, we have to treat with pessary and we have to just wait and watch for any complications in the pregnancy. Rarely we require laparoscopic uterine suspension if conservative measures fail. Then next is torsion of the uterus. This also very rarely we see in the pregnancy. Yeah. Uterine leiomyomas. This is very commonly seen in the pregnancy in 3.9%, 0.09 to 3.9% pregnancies we see. So what happens, effects on the pregnancy, what happens especially retention of the urine. The fibroid, what it exactly causes on the pregnancy. So there will be abortions, malpresentations, preterm labor, prematurity, IUGR. During labor, there will be inertia, dystocia, obstructed labor, PPH. In puerperium, there will be subinnolution, sepsis, secondary PPH. So these are all complications. Keeping in mind, every ANC visit we have to see for all these complications. During labor, we have to be cautious. And what exactly the pregnancy will cause to the fibroid, it will cause red degeneration. Therefore, that also we have to be very cautious. Acute pain in the pregnancy, fever which is not coming down with any medications, then we have to think about red degeneration of the fibroid. Uncomplicated, we can just follow the pregnancy routinely with usual ANC visits, but complicated, we have to go for the surgery like red degeneration. The next common thing is CS cervix during pregnancy. The incidence is 1 into 2,000 women. These women are often multiparous and over the age of 35 years. The squamous cell carcinoma are more common, 75% than the adenoCA, 25%. Complaints of blood-stained water or offensive discharge, postcoital bleeding or frank vaginal bleeding during pregnancy of these patients. But we will not disturb the pregnancy if it is at near the term, because we can just give her steroids and we can take it out the baby, then we can treat the woman with either hysterectomy or whatever is required. But before 20 weeks of pregnancy, we can just do hysterectomy with baby in uterus. Then ovarian CA, the incidence is 1 in 10,000. In second and third decades, most likely the dysgerminomas, granulosa cell tumor and teratomas, but in fourth and fifth decade, most likely epithelial origin. Common complications of ovarian tumor are torsion, hemorrhage, that we have to see. Emergency laparoscopy or laparotomy for detorsion we have to do. Hemorrhage is managed conservatively. Pregnancy does not alter the prognosis of ovarian malignancies. Breast cancer, about 15% of breast cancer occurs in women under the age of 40 years and 1% occurs in pregnant women. Sonography, we can go for FNSE, mammography, biopsy. After all, it's a multidisciplinary approach that includes an obstetrician, surgeon, and medical oncologist, and collectively we have to help the patient and do for the benefit of the patient. So in my conclusion, I would like to just tell that reproductive problems, there are n number of problems. They are in gynecology and obstetrics, they are in bulk. Routinely in day-to-day practice, we come across with very few. Early diagnosis and treatment is the choice. Screening method should be used. High index of suspicion is important in gynec problems. With this, I would like to say thank you. Thank you, ma'am.
Hello.
Yes, Sanjana ma'am, please.
Hello.
Hello.
Yes, ma'am.
Ma'am, I request Meenakshi madam to speak few words on this topic.
Good evening, everybody. At the outset, I would thank Dr. Sanjana Tallur and team, the organizing team, for giving me this opportunity to share the session.
Information.
Dr. Jyotsna,
Now
it was a
I
very
request-
elaborate session on the common gynecological disorders. She dealt right from adolescent to reproductive age, group to menopause, all the various common gynecological problems. So in the adolescent, actually we have dysmenorrhea and the PCOD and PMS. All these problems are common. So here mainly we have to stress on the sex education, lifestyle modification, and the vaccination against HPV. In the reproductive age group, mainly we have to stress on the leukorrhea, STDs, and the PID, also the family planning procedures. And she also stressed a lot on the pap smear screening for CA cervix. And again, at the menopause, we have AUB, where we have to go for the endometrial biopsy to rule out the precancerous lesions and prolapse. And also important in the menopause is we have to deal with the menopausal symptoms, and accordingly we have to manage the patients. So it was a very extensive session by Dr. Jyotsna. Thank you again.
Thank you, ma'am.
Thank you, ma'am. Thank you for chairing the session. Prachi?
Unmute yourself.
Hello, Prachi?
Yes.
Unmute.
Thank you so much.
Hello, her
Now
signal is weak, I
Yeah,
think.
Dr.
network
Next
is.
talk is by Dr. Rameshwari Marchetti. She is a faculty of Bidar Medical College and young enthusiastic girl who has finished post-graduate from our college, that is MR Medical College. She'll be talking about Let's Talk on Menopause. And the session will be chaired by Dr. Manpreet Kaur, who is a senior consultant and also IMA WDW chairperson, Karnataka State Branch, and she is ex-faculty and head HOD of Alamein Medical College and also a BLD University. At the same time, as she is traveling, it will be chaired by Dr. Anuradha Parmesh Madam also. So, if there is a miscommunication, Anuradha Madam will take the
Yes,
will act as a chairperson. Now,
Dr. Sanjana?
Yes, ma'am, you are there, ma'am?
Yeah, I'm here. Yeah, I'm there. But again, Dr.
Yes,
Anuradha
ma'am.
ma'am, if she's also.
Both can chair the
Okay.
session.
Okay.
Now, I request Rameshwari to.
Okay, good evening, ma'am. Thank you for such a warm welcome of mine. I am actually overwhelmed to talk on all of my seniors present here. I would like to thank IMA KSB and IMA Bidar branch for giving me this opportunity to talk on today's topic, that is menopause. I request co-host sir to please share my slides. Yeah, thank you. Okay, fine. So my today's topic is, let's talk on menopause. For the first, I want to give the definition. The very first definition we should know, as many guidelines have a different definition, but these are took from the Indian Menopause Society. And it includes it should be 12 months of amenorrhea. There should be a retrospective diagnosis always. And it includes depletion of the ovarian follicles, diminution of ovarian hormones. There should be no independent biological marker and objective sensitive marker of irregular cycles. So I just want to say that there is no need to conduct the test routinely to diagnose menopause. It can be done clinically also. Next slide, please. So how to diagnose? The important laboratory test which we require, that is first the serum FHS level, which is more than 40 milli international unit per ml. Serum estradiol, which is less than 20. AMH and inhibin B will be lower side. Ultrasound will always show a lesser antral follicular count. Next slide. So this picture depicts how the transition in women's life occurs, starting from menarche to pregnancy to menopause. All my two seniors have covered about puberty and the other problems. I will be dealing more in detail with the menopause. Next. So how to diagnose? So important diagnosis is first the history wise. That is always the symptoms are important, like what the patient is suffering, like hot flushes or etc. And what are the signs we have to look after, in which the lateral vaginal smear is very important. And we have to give a medications like to know whether it is anovulation or not, including the progesterone withdrawal and the response to HT. So few definition I would like to enlighten here. That is, what is premenopause? Reproductive period prior to menopause. What is perimenopause? That is 3 to 5 years before and 1 year after the menopause. Menopause transition is disturbed menstrual cycle and it has endocrine changes into it. So other definitions. What is postmenopause? It is the span of time dating from the final menstrual period, regardless of whether menopause was spontaneous or iatrogenic. Senescence, it is the period after the age of 60 years. So what is premature menopause, which is very commonly we are seeing nowadays to our OPDs, that we have to be very specific of the definition in premature menopause. That is the spontaneous menopause occurring 2 standard deviation we take, and the mean estimated age usually we take below the age of 40 years. But in Indians, we also consider it below 38 years as per the guidelines given by 2012. So what is early and the delayed menopause? Early menopause, it is the time span between the spontaneous or the iatrogenic menopause occurring between the age of 40 years and the accepted typical age of menopause for giving population. What is delayed? Usually we take after the age of 54 years. It is usually occurs due to hyperestrogenism and it is usually after the age of 54 years. Next, what is induced? Induced is something that is cessation of the menstrual that flows due to a oophorectomy or due to any iatrogenic ablation of the ovarian function. So it is induced. Temporary menopause word nowadays we are not using because menopause is almost, it is a permanent cessation of the menstruation flow. So rarely we use the temporary menopause, which is not very correct in this scenario. What is postmenopausal bleeding? So postmenopausal bleeding is occurrence of the vaginal bleeding following a woman's final menstrual cycle and is not on cyclic hormone therapy. But the vaginal bleeding that occurs 6 months after the amenorrhea should be considered suspicious and warrants investigation always. So what is the age? The age at natural menopause, as per the Indian guidelines, it is 46 to 47 years. But as per the Western guidelines, they considered it to be 51 years. So both modified. So some systems of classification is given by the Indian Menopause Society Consensus Group. There are two modified classification. That is, one is the ankle Syria staging and other is the stages of reproductive aging workshop, which is called as straw classification. These classification are important in view of clinical purposes for the treatment to menopause. So I would like to enlighten this slide very much because this is the clinical patients we are getting in our OPDs, and we have to, it will be very easy if we divide as per stages and give the treatment. So as per stage 1, stage 2A, 2B and stage 3 divided into 3 stages. In stage 1, we roughly consider 2 years before menopause. It is early premenopausal symptoms having 1A and 1B. 1A is only the vasomotor symptoms. So we are going to treat here as a preventive or a treatment as vasomotor symptoms. And 1B, she will be having the psychosomatic symptoms or other menstrual problems also. In stage 2A, that is 1 year after the last period, there will be few atropic changes, there will be few genitourinary changes, there will be a vasomotor changes, there will be weight gain, and there will be osteopenia. In stage 2B, up to 5 years after the menopause, there will be intermediate symptoms here, that is post-menopausal symptoms. They will be having late psychosomatic and genital symptoms, sexual disorders, residual changes from stage 2A, and more going towards the osteoporosis in stage 2B. Stage 3, it is 5 years post-menopausal till the late menopause, having almost all the complications here like residual changes from the stage 2, ischemic heart changes and other late complications like Alzheimer's and the osteoporosis. So we have a lot of window of opportunity here to treat, first to prevent, then we can treat, then we go for the palliative surgery. So it is always we diagnose at the early phase what actual signs or symptoms she is having and go for prevention and treatment. Next slide. So coming to the symptoms, 88% of the women are symptomatic. That is symptomatic, they'll be having all hot flushes, sweating, night sweats, etc. 25% of women will have a severe symptoms, and symptomatic women are 8 times more likely to report issues with the low workability. That is, they have a loss of work, they have a loss of office and other features. Next slide. So these are the menopause in a short, giving you a one slide that what all problems the female will be facing in the phase of the menopause. Next. So I want to just tell this slide when the medical intervention is required in menopause. So initially we have diagnosed, initially we got that she is into the menopause. We have diagnosed as per the criteria and the stages. But the most important at the age of 40 to 50 years, 50 to 60 years and the post 60 years. So first 40 years she will develop having the vasomotor symptoms, sleep disorders and the mood changes. Then in the next, the more problems will be with vaginal atrophy, dyspareunia and skin atrophy as the estrogen levels get depleted as the age as she ages to 60 years. And the late after 60 years, she'll be having most of the osteoporosis, atherosclerosis, coronary heart diseases, and the cerebrovascular diseases. So this is at one slide. She will be having with hot flushes. She will be having night sweats, changes in the periods, irregular periods. She'll be having weight gain, problems with the bladder, having urinary incontinence, vaginal dryness, loss of interest in the sex, mood changes, sleep disturbances, forgetfulness, headache, backache, loss of hair on the head, new hair on the chin, muscle, and the joint pain. So many transitions occurs at the menopause. So who should manage? So most important, the first visit of a it will be to a gynecologist, usually the first point of contact, but it is not only the gynecologist who are going to treat it. She requires a team of physician, orthogeriatric medicine, psychiatrist, cardiologist to have her a good outcome and a treatment. So one thing here is menopause clinic, which is very, very unaware. I feel in India, still the awareness has to be created on the menopause clinic. As far as the Western countries is considered, they are very clear about menopause clinic. Many of them come to the clinic, take the advice, get detected. But in India, as it's our duty to make all the public aware of what is the menopause clinic and what actually it is, so that they can prevent and treat all their conditions and share what they are feeling at their age. So minimum basic requirement what we have here is we have a core team of gynecologist, a nurse, a receptionist, and secondary team of the other visiting consultants. And also we should have a equipment like examination table with lithotomy position, measuring tape, weighing machine, BP apparatus, speculums, pap smear kits, and the laboratory and collection centers. Next slide. So this is menopause performer, which is given on the Indian Menopause Society organization. You can go to this link or a website and you can get this performer. It is very nicely given as it is divided as per the history, as per examination, what treatment she is receiving and her follow-ups for the next of her survival. So you can assess through this website. Next. So what is the physician role? Actually, we always think that is gynecologist has to play a role here. It is the most of the time the gynecologist has to play, but we have to take the physician's help to make it in the symptomatic cases when the other complications occurs in the menopause. So what to be done? We have to first assess the symptoms. We have to go ahead with the physical examination. Then we have to investigate. So management again comes in two groups. That is one, women without menopausal symptoms, and group two is women with the menopausal symptoms. So physician's role in each group is to find out what are the comorbidities, what are if she is having any other diseases associated with the menopause, like if she is having diabetes, if she is having hypertension, any cardiac condition. So at the first onset, we have to get with the history, then we have to go ahead with the examination, and we have to classify her whether she comes into the first group or to the second group. And as well like that, we have to go ahead with her management with lifestyle or a pharmacotherapy after the risk and benefit analysis. So everyone knows her. I hope everyone knows the Basanti. She's same what she was at her Sholays, and today also she is the same. So the quote goes with her: a young woman is a gift of nature, but an old woman is a work of art. Even I accept this because the Basanti is same as today. So it shows the importance of menopause clinic, I feel. So is this woman peri or post menopausal? We have to divide first. Then we have to ask the first question comes to ours is, when was your last period? So if it is less than 3 months ago, regular bleeding, it will be in premenopausal. If less than 12 months ago, irregular bleeding, she will be in perimenopausal. If it is more than 12 months, then it has occurred the natural menopause. Then the next question comes whether the removal of both ovaries. So we have to get to know whether it is a surgical menopause or a natural menopause. So how to assess? This is very important to assess. The assessment goes with a medical history. That is menopausal symptoms. We have to ask what is her bleeding pattern? What was her last menstrual period? Any surgery she underwent like hysterectomy or oophorectomy? Any current use of hormonal therapy or any contraceptive if she is receiving? Any dietary history, sleep history, sexual history, postnatal depression, other like risk assessment of other comorbid conditions like diabetes, hypertension, DVT, thyroid, liver, osteoporosis, climatic depression, dementia, and various numbers of cancers. Then we have to see for the family history if any cardio or cerebrovascular disease is there, osteoporosis, fractures, dementia, and cancer which run through the families. And any current medication, including the hormonal, if she is taking, and what is about her social and personal history, any history of other tobacco or the alcohol use. We have to cover all this point in the history. Coming to the examination most important whenever it is the patient is coming to the menopause clinic, we should always make her comfort, ask her the proper history. Then we have to go ahead with the examination. First goes with the height and weight, blood pressure, other systemic examination, and most important is the pelvic examination. We have to take up the pap smear, breast examination, thyroid examination, and nowadays we are going to assess the mood and cognition also, other eye checkups and the dental checkups we have to see. Next, other laboratory tests which is required in diagnosis are the complete blood picture, urine test routine, fasting blood glucose level, lipid profile, serum thyroid stimulating hormone, pap smear, transvaginal ultrasound, and mammograph. So these are the important basic investigation we have to get it done. If other further required, then we have to go ahead with the targeted other investigations. So the health checkup at a one slide, it is we have to go ahead with height, weight, then the breast examination, we have to go with blood pressure checkup, blood testing or the usual laboratory testing. We have to go with pap smear, bone mineral density test, ultrasound of the uterus and ovaries, and the waist circumference, which are the common to be checked at our clinic. Next. So recommendations of DXA scan in Indian females are all women 5 years beyond the age of natural menopause, women less than 5 years since menopause with a particular risk factors, women with fragility fractures, women in menopause transition with secondary causes, radiological evidence of any osteopenia, and the presence of vertebral compression fractures. So these are the guidelines to go for DXA scan. Otherwise, it is not mandatory for all the menopause females. So what are the, before initiating pharmacotherapy for osteoporosis, the interval testing should be based on calculated individual risk, and it should be scheduled between 1st to 5 years later of the post-menopause. So this is, everyone knows the slide, that is what is the normal level of the T-score, that is -1 to +1 standard deviation. And if it is goes to less than -2.5 standard deviation, it is called as osteoporosis, and most of the women comes in the category of osteopenia in our clinic. Next, and it should be measured at the hip spine levels. How to investigate? So pre-menopause, peri and the early menopause, and the post-menopause. We have investigated and we have got to know that she is either in the pre-menopause, peri, early, or the post-menopause. Now we are going to the plan of management. First is therapeutic lifestyle management, health concerns. We have to get to the history, general health and disease management like lifestyle, such as physical activity, her diet, smoking, alcohol, and obesity. All we have to ask her to cut down. And any contraceptive, if she is having irregular bleedings, we have to advise her for the contraceptive. Management of other symptoms like menopausal symptoms, vulvovaginal atrophy, we will have to give the hormonal replacement therapy in the form of oral hormonal replacement therapy, estrogen progesterone combination, or you can go ahead giving as a ring, giving as a gel, giving as a patches, or other forms which are more beneficial, but all these should be in the lower dose, so that it will be beneficial to her. And the prevention of osteoporosis like phytoestrogens and other drugs, bisphosphonates, calcium, vitamin D3, 1500 per day we have to give. Sexual dysfunction, we can again go ahead with the vaginal creams or the pessaries, which we are using, replacing every 3 months, containing the estrogens. Next. So again, management, as I said, it should be a woman without menopausal symptoms, and the other group T is woman with the menopausal symptoms, with and without it is. So the woman next. So we have to group 1, woman without the menopausal symptoms. The woman is healthy with no problems. If she has had no symptoms, then institute the preventive and promotive care. Ask her to come to a regular counseling. That is enough. Healthy woman with risk factors for a disease, but there are no risk factors. Again, you have to evaluate with all the basic assessment, institute preventive health care in her. So no treatment is required at this phase also. The counseling itself is enough. Third, women with a latent disease or any pre-disease, no symptoms still. So you have to evaluate, treat the disease, and again have the lifestyle health care. Women with other comorbid condition, but still the symptoms are not there, treat the disease, institute the individualized lifestyle health care. Next. Coming to the group 2, here the woman will having the symptoms. So healthy with no problems, but she has the symptoms. Here also you can go with the counseling, plus you can also have the hormonal therapy as she has come with the symptoms of menopause. Healthy with risk factors for disease, symptoms of menopause, institute preventive health care, risk benefit analysis, therapeutic intervention might help here as she is having symptoms. Next. Women with latent disease or symptoms of menopause, here also we have to counsel her, but again we have to give a therapeutic the intervention here in the form of HRT or in the form of other measures so that her symptoms get reduced. And the woman with comorbid conditions having the symptoms of menopause, we have to counsel her, we have to treat her, and we have to follow her in the group D condition. Next. So very important, I would like to stress on this is the stress management in the menopause, how we can help. So stress reduces the production and effectiveness of the sex hormones as it prioritizes production of stress hormone, which is cortisol. So how will you manage the stress? The most important, hand in hand, self-care. First, fill your cup before the others. There should be a yoga and meditation, deep breathing, and the natural beauty. You have to always have the social gatherings. Next. So other ways how you can manage is you have a connection, encourage them to stay connected with their social network. You have a sleep, uninterrupted sleep for emotional stability and cortisol control. You ask them to put a free sleep apps, the females who are not getting the sleep, having insomnia, to put a sleep time circle, to put a time alarm, to put a pillow and make them to have a nice sleep, supplements them with the vitamin B3, vitamin B6, vitamin D, and magnesium and omega-3 acids. Psychotherapy in the form of CBT and talk therapy will also help her, and HRT that is also helps and improve the mental health. So this is the stress management in the menopause. Okay, the next most important is the cosmetic in menopause. So what happens in menopause is the decrease in skin collagen in the menopause is 1 to 3% per year, having more of the wrinkles on forehead, at the eye edges. There will be all the on faces wrinkles. So what you can help her, how you can help her to look her more beautiful and more confident in the menopause. So few things which I am going to elaborate next. So first is the term which we called here, it is called as menopause makeover. So in that we are using the injectable neurotoxin, we are using the dermal fillers, we are using the other methods to treat this. In injectable neurotoxin in the form of Botox, we are giving them. In dermal fillers like hyaluronic acid patches or a voluma injections, we are giving them. If they have developed the excess facial hair, we are giving the option of a laser hair removal like Epilase hair removal system. If they have a loss of hair, then also we are giving the lattice eyelash enhancement or eyebrow enhancement. If they have acne scars, then we are going ahead with a skin pen microneedling or a collagen induction therapy, and also the UL therapy. As in menopause, the skin thinning will be there. It will help in the skin thickening. Next. So what conclusion goes is women represent a talented and experienced cohort of the working population, and yet most of the time we are silent on their needs during the menopause and lacking adequate knowledge to address their issues. So we need to create menopause friendly workplaces that achieve a much needed level playing field for a woman at work, allowing them to continue to achieve their full potential as members of the working community. And as today's topic flyer name is We Women, so I think the we itself gives a lot of strength. So to all come together and provide awareness among our own society and make them feel that they are still young. So I conclude. Next slide. So I conclude with this. So the World Menopause Day is celebrated on the October 18. So I believe wholeheartedly that age is a just mindset. Biological age is what it is, but I truly believe it's more about how you feel in your body, and how you feel about your body. Thank you, everyone.
Thank you. Thank you, Rameshwar.
Hello. Am I audible?
Yeah, you are audible,
Okay.
Dr. Manpreet.
Yes, Manpreet.
Okay. At the outset, I would like to thank IMA KSP and Dr. Sanjana for giving me this opportunity to chair this session. It's an important session, menopause, and most of us are ignoring it because, yes, it is a normal transition, but as Dr. Rameshwari has very elaborately and very nicely conveyed today in her talk, there are some things that we need to take care of and some things that we should consult a gynecologist or a physician, because osteoporosis and the pre-malignant lesions and the malignant lesions have to be looked after by an expert, and not just not by what I feel about my body or the lady is feeling about her body. Madam Dr. Rameshwari, Rajeshwari, it was a very nice talk. You covered all aspects of menopause, and I think it was a wonderful talk. Thank you so much. And thank you, Dr. Sanjana, for having me here.
Thank you, ma'am. Thank you, ma'am. Anuradha, madam, anything you want to say about this?
Well, I would like to congratulate all the three speakers for their elaborate presentation, touching each and every aspect of each phase of a woman's life. And sincere thanks to all the three speakers for a wonderful presentation. And definitely hats off to our WDW subcommittee chairperson, Dr. Sanjana, not WDW, it is the academic subcommittee. For wonderfully getting good speakers to give us good information. Thank you, and happy Women's Day to each one of us. Every day is a Women's Day for us. That's how we need to take it. Let's celebrate each day.
Thank you, ma'am. Some questions are there, so I will read out the question. To whomever it is related, you can answer it. Okay. Does metformin used in PCOD causes hypoglycemia in the euglycemic adolescent? Dr. Savita, I think you should answer for this question. Does metformin used in PCOD causes hypoglycemia in euglycemic adolescent? Anyone can answer, all the three. Does metformin used in PCOD causes hypoglycemia in euglycemic adolescent? So these are the questions on YouTube, so you can't see them.
Hello, ma'am.
Yes.
Metformin doesn't cause any hypoglycemia in euglycemic patients.
Okay. One more question is causes for white discharge in adolescent girl. I think this is for Jyotsna or Savita. Anyone can answer this question.
The most common cause, yes, sir, ma'am. Most common cause for white discharge in adolescents will be physiological only, and anemia is the most common cause for that. Other causes can also be because of any foreign body reaction or foreign bodies. That could be the cause in adolescents.
Okay. One more question, like treatment for stress incontinence in middle-aged women.
Yes, ma'am. In middle-aged women, stress and incontinence, like we can go for simple Kelly stitch if it's like, not very severe. But if it is like, it is like, disturbing our day-to-day routine life, then we can go for the sling operation, laparoscopical.
Okay. So one advice they have given, like education of adolescent student as well as parent, especially mothers, will be very helpful or not. They have advised, like they want advice.
Yes, ma'am.
Whether educating mother along with the girl is helpful or not.
It is very helpful, madam, because parent and adolescent both has to be educated. Even we as a parent are at par to accept what is going on in our adolescent. Even we need to be educated about that, accept that the changes, what is happening and how they are behaving. Simultaneously, the adolescent is also very, very, very important to educate the adolescent, because they are facing a changes in the body, which is something new to them. So both have to be educated for acceptance of each other's.
Okay. Now I request Dr. Mallikarjun Panshetty to say vote of thanks.
Good evening, all. I first of all would like to thank the IMA KSB, the President, Dr. Lakul sir, the Honorary Secretary Karunakar sir, and the Chairman of the Academic Committee, Dr. Sanjana, for giving IMA Bidar an opportunity to conduct, along with the IMA KSB, this webinar on this special day World International Women's Day. And I wholeheartedly thank the chairpersons, Dr. Anuradha Madam, the past Vice President of the IMA KSB, Dr. Meenakshi Devarmani Madam, Professor, Department of OBG, MRMC Gulbarga, and Dr. Manpreet Kaur Madam, the Chairperson of the IMA KSB Women's Doctor Wing, for being taking out the time and being the chairpersons of these webinars. And I definitely a big thank to all the speakers for giving a wonderful talk. They have been preparing since last 1 month and they are waiting for this day to present their topics. And special thanks to all the 3 members. No words to describe their efforts. They have taken out a lot of time from their routine busy schedule, prepared well, rehearsed, and at the same time presented in a very lucid and a simple way so that it can be understood even by a simple MBBS fellow also. They need not have to be an obstetrician or a gynecologist to understand these topics. A big thank to all of you, and a special thank to all the members who have joined through the Zoom app or also to the YouTube. Some have had a difficulty in joining the Zoom. They had joined the YouTube. Good number of people have joined this. And I think it's a big success for the IMA Bidar along with the IMA KSB for conducting this webinar. We would have been much more happier had some more people have joined, but nonetheless, it's still a good success for us. And
Dr.
on this
Mallikarjun, I request you to speak about our upcoming NatCon, not NatCon,
yeah,
Medcon.
yeah. Yes,
at
about to
Bidar.
start. Yeah, I was just waiting for this slide to come on the screen. As you all know, the Bidar IMA has the host for the Medicon 2023, which will be conducted at the Bidar Institute of Medical Sciences. Recently, a team led by the President, Dr. Lakko sir, Dr. Madhusudan Karigar sir, and Dr. Bakka sir has visited Bidar. They had been to the venue of the conference. They were very impressed and they are hoping to be one of its kind of Medicon to be remembered for a few years to come. And they had also seen the places of the nearby tourist places, and they all are very much eager to see it conducted in a very memorable way. On behalf of IMA Bidar, I request all, along with our Taluka branches like Baswakalan, Humnabad IMA and Bhalki IMA, we are all requesting all the IMA members to register for this conference. The registration fees have been displayed on the screen. Lots of members are already joining as a delegates and also along with that accompanying person. Bidar, being the crown of the Karnataka, has a wonderful places to visit. It's not about just the academic activity of what we are conducting. There are lots of tourist places of historical importance. First of all, would like to mention them is the Baswakaland, where there is an Anubhav Mandap, which was called the Parliament of 12th century Parliament. Along with that, we have 14th century fort in the Bidar, and many historical places and of religious importance places are there in the Bidar and around the Bidar. And Bidar is very well connected, as most of may not be knowing the people in the south that how to reach the Bidar. We have an airport in Bidar. There is a domestic flight from the Bangalore straight to the Bidar. And also the Hyderabad, which is just 2 hours drive from Bidar, is an international airport. So any members from any part of the country can also come to Bidar to join this Medicon. And we are very eager to receive you all, and we want to make it a memorable event. And for this matter, I request everyone, whoso members, to register at the earliest and give us an opportunity to showcase our talent as well as our hospitality. And it will be one of its kind for the Bidar, which is conducting for the first time a state level conference. With few words, I am requesting once more to all the IMA KSB members to register at the earliest for the this upcoming Medicon. And through the Secretary, Honorary Secretary Karnakar sir, would like to request my request to send this message through various branches of the Karnataka state, IMA state branches. Thank you, Dr. Sanjana, once more for giving us an opportunity to highlight not just about the webinar, what we are conducting, but also about a platform to tell about the Medicon, which many may not be aware that we are hosting, Bidar IMA is hosting.
Okay.
Thank you, madam.
Thank you, Malu. And I request Anuradha madam to carry this flyer all over the state because she's a very active member of IMA and she connected it very nicely to each and every person. Thank you, ma'am. I thank all the speakers and the chairpersons for accepting my invitation and be there IMA and our president, sir, and secretary, sir. Thank you, ma'am. You can leave the meeting, ma'am. Thank you.
Thank you. Thanks a lot.
Thank you, ma'am.
Thanks all.
Thank you so much.
Thank you.
Thank you, sir. Thank you.